Hi, and welcome to your lecture on Chapter 32, which is GI System Function Assessment. Okay, so let's talk about the learning outcomes. We are going to, by the time we're done, be able to list all the structures of the GI tract as well as the accessory glands, which are the liver, the gallbladder, and the pancreas. We're going to be able to describe and explain the functions of each of those. We're going to talk about aging and how the aging process affects GI tract and the accessory glands. We are going to list data collection techniques when we're taking care of patients that have these kinds of pathophysiological disorders. Differentiate when we're obtaining data from a client, what's normal, what's not. Techniques that we use when we're conducting a physical examination of the abdomen and the GI tract. We're going to talk about diagnostic tests. We're going to talk about types of tubes, nasogastric tubes, PEG tubes, etc., and how we care for the patient with those tubes. And we are going to move on into specificity with the other chapters in GI. So the first slide is an anterior view of the digestive system. It shows you all of the organs that are involved. So you've got your mouth, which is where mastication or chewing takes place. Your parotid glands, salivary glands, release saliva, helps you chew the food up so you can swallow it, goes through the pharynx, epiglottis, through the esophagus, then down to the lower esophageal sphincter, which is a little one-way door so that the food goes down the esophagus, the sphincter opens, food goes in the stomach, boom, and the sphincter slams shut to keep everything in the stomach, stay in the stomach. In the stomach, hydrochloric acid gets released in response to the food that's in there. And the hydrochloric acid breaks down whatever food is in the stomach into a pureed kind of baby food looking mush called chyme. So once that happens, the chyme leaves the stomach through the pyloric sphincter, another one-way door that will open to let the food out of the stomach into the small intestine and then slam shut. It's pyloric sphincter. Then the food travels through the small intestine. Small intestine, the way to remember it is DJ ileum, okay? Duodenum, jejunum, and ileum. It's about 20 feet of small intestine, and that's where all absorption takes place. So everything that you eat, whether it's lipids, that they're fats, proteins, carbohydrates, which are sugars, either simple sugars or complex sugars, vitamins, minerals, electrolytes, all those things get absorbed in the small intestine. By the time they finish moving through that 20 feet or so small intestine, they go to the large intestine, which is also known as the colon, and that's basically about the absorption of water and formation of feces. Okay? And the large intestine, otherwise known as the colon, is the anterior or the ascending, transverse, and descending colon. It's where the stool is being formed, which lead to the rectum and then Uranus. Uranus always makes me laugh. Anyway, and then there's another slide here that I've put in that has a better breakdown of each of those accessory organs and main organs of the digestive system, tells you what they do. Okay, so here's a list: GI anatomy and physiology, goes through everything that I just talked about. Okay, this next slide shows you the liver, the gallbladder, pancreas, and the duodenum. And we're going to break down each of the accessory organs, okay? So the liver, the gallbladder, and the pancreas are the accessory organs. And they have different jobs, and their jobs are related to either producing or storing different types of digestive secretions. So things that your body needs in order to absorb nutrients and so on from the foods that you eat. So we'll start with the liver. The liver is on the right-hand side. It's the right upper quad, kind of underneath the ribs. And at the liver, you have what's called hepatic portal circulation. So there's kind of a little subset of circulation that goes on there. So if the liver becomes damaged, that portal circulatory system does as well, and it affects things like fluid retention and blood pressure. Okay, and then the other thing the liver does a lot, by the way. The liver also hangs on to or secretes bile. Bile is needed for the absorption of lipids or fats. And a fun fact, bile is what makes your poop brown, okay? If you don't have any bile, your feces will be chalky, kind of chalky consistency and color, whitish, grayish, because there's no bile. What does the liver do? Well, the liver helps to metabolize carbohydrates, amino acids, and lipids, so sugars, proteins, and fats. The liver synthesizes plasma proteins. Albumin is a plasma protein. Fibrinogen, which is a product of prothrombin, and prothrombin, which is a vitamin K dependent protein that's also known as factor 2 that assists in the formation of clots. So the fibrinogen and the prothrombin have to do with your blood's ability to clot. So if your liver is broken, in other words, maybe you have liver disease like cirrhosis or hepatitis, liver cancer, you're going to have an issue with bleeding, right? Makes sense. And then the albumin, which is another different type of plasma protein, is an indicator of nourishment, the ability of wounds to heal. You need that particular plasma protein. People with liver disease will have very low albumin levels. The liver also performs phagocytosis, which is the breakdown of old red blood cells or hemoglobin by these Kupffer cells. So in other words, red blood cells live about 120 days. When they're old and they're ready to die, they go to the liver, and the liver will break them down. So the hemoglobin goes there. The liver breaks down the hemoglobin, takes the heme, which is the iron, takes it out and stores it, takes what's left, which is the red blood cell, breaks that down, and the waste of that is bilirubin. And bilirubin is what the liver gets from the breakdown of the red blood cell and is supposed to excrete it through the feces. People with liver disease, you notice they are jaundiced. They have a yellow tinge to them. Why? Because their blood levels of bilirubin are elevated because of the liver disease. Okay? The liver is responsible for storage. It's like a storage facility. So it will store fat-soluble vitamins. They are A, D, E, and K. And also it can store glycogen, sugar. The liver is responsible for detoxification. So it filters toxins out of the blood, like medications. A lot of medications are excreted via the liver. Acetaminophen is a big one. And then also there's something called ammonium that is supposed to be excreted. It's a waste product. If the liver is not working properly, guess what? It won't be able to excrete medications, so a patient can become toxic, and won't be able to excrete ammonium, which in the blood is ammonia, which is a thing that can cross the blood-brain barrier and cause something called hepatic encephalopathy, which is significant confusion, cognitive change because of that ammonia. We'll talk about that later when we get to liver specifically. And the liver is responsible for the activation of vitamin D, and you need vitamin D in order to absorb calcium. So the liver is pretty important, okay? The gallbladder stores bile. And when you have ingested foods that have fats in them, lipids, the gallbladder will release the bile through something called the common bile duct. So the bile will leave the gallbladder, go into the small intestines, and that's how you can absorb the lipids from the foods that you eat. Then you have the pancreas. Now, the pancreas is endocrine and exocrine, but we're talking about its exocrine function. The two things you need to know: pancreatic enzymes, amylase and lipase. Amylase is what you need to convert starch to maltose. So in other words, those complex carbs into a more simple version. And lipase helps you take fat, real emulsified fat, and turn it into a fatty acid that's more usable by the body, okay? We'll talk about aging. Aging effects on the GI system. I mean, just all the way down the line when you look at this flow chart, things that happen with, when people age include tooth enamel starts to get a little more brittle, so you're more likely to chip a tooth. The tongue will start to atrophy, get a little bit smaller. And when it gets smaller, your sensation of sweets gets lost. Saliva production gets decreased. Motility in general, motility means movement, right? So motility of the esophagus and the stomach and the intestines all slow down. When that happens, then, metabolic rates are slowing down with age. And so it takes longer for food to move through, get absorbed. People get constipated when they're older. There's a weaker gag reflex. And so dysphagia becomes something that is more common, which places older people at a higher risk of aspiration pneumonia, okay? You can read through the rest of the things that can happen with aging. And again, happens to other people, not to me, just so we're clear. We'll talk about more specific things as we move through the next few chapters. The gallbladder also, one of the things that can happen with aging is the formation of gallstones. And gallstones are basically stones that form from an accumulation of fatty acids. And when those fatty acids start to accumulate, if they don't pass through quickly enough, they can get hung up and clog the common bile duct. If that happens, the patient will have cholecystitis, which is an inflamed gallbladder, and it may require removal. Okay? And again, we're going to have one chapter dedicated to the liver, the pancreas, and the gallbladder. This is kind of an overview. When you're collecting data, you always want to make sure you get a very comprehensive health history. Where has the patient traveled to? Any other countries specifically? What is their typical elimination? Do they move their bowels every day, every other day? What medications are they on? Antibiotics, we know, can cause C. diff, right? Nutritional assessment. What do they eat? How often do they eat? What cultural impact is there on their diet? And of course, family history is important because there are lots of diseases that do run in families. So that's important to assess. And then you're looking at their height, their weight, their BMI, their oral cavity. Somebody that's missing teeth or edentulous is going to be at a higher risk for nourishment issues like malnourishment if they can't chew properly, right? We're going to be looking at the abdomen. Is it swollen, distended? Is it tender? When you're looking at a patient, do they appear jaundiced? And then, of course, we'll be auscultating and palpating and looking at things like abdominal girth, which can be signs of liver disease. When you look at this next slide, you can see that the abdomen can be divided up either into quadrants or regions. And so for the sake of quads divided into 4, you have the right and left upper quad, and then the right and left lower quad. And that's important because when you're auscultating, what you're hearing and where you're hearing it will tell you or clue you in as to what might be going on with the patient. When you look at the regions, you can see that it's now divided up into 9 abdominal regions. And so that's important because if the patient's complaining about pain, where is the pain? Is it epigastric pain, which is up high? Or is it hypogastric, which is down low? Okay? And then lab tests. So you need to be looking at their CBC, right? So you're looking at their white blood cell count. Is it elevated? Sign of infection. Electrolytes, potassium, sodium, magnesium, calcium, phosphorus. Carcinoembryonic antigen, CEA, which is a test that talks about the risk of cancer. Bilirubin, total bilirubin, if that's elevated, liver disease. Liver enzymes, AST and ALT. Pancreatic enzymes, amylase and lipase. And then we have stool tests, like the stool for occult blood, also known as a stool guaiac, and then a gastric fluid pH analysis. So I'm going to put on here all the norms, what they should be and what you should find and what procedures are, so this way you have all that information available to you. And then when we talk about tests, a radiographic test or a test that's done under fluoroscopy, all those words mean the same thing, under an x-ray, under an x-ray. So we can x-ray the abdomen. We can have the patient swallow this stuff called barium, which will illuminate when it's inside them, and then we can do an x-ray and take a look and see if there's an obstruction somewhere. We can do a barium enema. Now, instead of them drinking it, we can give them an enema with barium and put them under an x-ray to see if we see anything, cancer, lesions, tumors, blockages, etc. We can do CT scans. Right? We can do angiography. And angiography, whenever you hear that word, angio of blood vessels. So in other words, we're looking at blood flow. Angiography is usually looking at hepatic portal circulation. We can do a scan of the liver. Okay. We suspect liver cancer. And then we can do oscopies. Okay. Whenever you see oscopy at the end of a word, that means we're putting a scope in to look at something. Okay. A common one is an EGD, esophagogastroduodenoscopy. That's a mouthful. We're looking at the esophagus, the stomach, and the duodenum. We can do an endoscopic retrograde cholangiopancreatography, which is an ERCP. Don't worry too much about the EGD and the ERCP. Just understand that when we're putting a scope into the esophagus, the things that you're concerned about as far as nursing perspective is after the procedure. Is the gag reflex intact again? Because you wouldn't want to give them anything by mouth if it's not. And how do we assess the gag reflex to be sure that they're not going to aspirate? And it really is as simple as placement of a long cotton-tipped applicator, you know, those long Q-tips, to the back of the throat, right beyond the uvula, a little punching bag, and see if they go, okay, see if that gag reflex is intact. And then we can do scopes, but on the lower half of the body. So lower GI scopes would be a proctosigmoidoscopy. Don't worry so much about that, but colonoscopy. You must know everything nursing about colonoscopies. As far as bowel prep, in other words, what must the patient do to prepare for colonoscopy? Because the colon must be clear of all stool. When we put that scope in, we want to be able to see, you know, what's in there and what kinds of side effects and so on and so forth can happen with a colonoscopy, because there's a risk with anything invasive. There's a slide, a little picture of a gastroscopy. We've got the tube down his throat through the esophagus into the stomach. Okay. And with an ERCP, the things that we're looking at right here, going down the esophagus through the stomach with this little fiber optic scope, and it's going in and looking at the smaller structures within the pancreas. Okay. And then we can do ultrasound, etc. We can do biopsies, and a biopsy is the removal of tissue to send to pathology, so they can look at that tissue under a microscope and see if the cells are normal or typical, or if the cells are atypical, which could be considered precancerous, or if the cells are cancerous. Okay. Then we have intubation. So when we talk about GI intubation, we're talking about an NG tube, PEG tube, or a J tube. And so we're going to talk about tube feedings. In other words, when we're actually giving nutrition through a tube, and they can be given via a pump or via gravity. You're not going to see gravity that much, but pumps you will see. And feedings can be given as a bolus, in other words, whoop, one big amount every so often. Intermittent feedings, 2-hour feedings every 4 hours, or they can be continuous feedings. And we'll talk about the nursing care associated with those feedings. Okay, patient's head of the bed needs to be elevated so that they don't aspirate, et cetera, et cetera. When it comes to NG tubes, nasogastric tubes, they're either single or double lumen, and a double lumen NG tube is called a Salem sump. NG tubes are only flushed with 0.9% normal sterile saline. That's it. They are not flushed with water, sterile water, anything else, just normal saline. And before an NG tube can be accessed, placement must be verified. And there are 2 ways to verify placement. Number 1, an X-ray. And with an X-ray, it's either in the stomach or it's not. Okay, that's 100% accurate verification. Number 2 is aspiration of gastric contents or gastric residual. So it's where you take a syringe and attach it to the end of the NG tube and aspirate or draw back to pull up some of the gastric contents, and you dipstick it for the pH. And the pH of the stomach, because it's hydrochloric acid, should be acidic. In other words, it should be less than a 5.0. Okay. And then I put a slide in with a couple pictures of a normal single lumen, also known as a Levin tube, and then a double lumen Salem sump. And the second lumen on the Salem sump is also known as a pigtail, and that is actually just a vent. So it's not used for flushing or anything like that. It's just a vent. And that's usually the tube that you'll see for gastric decompression, secondary to either a bowel obstruction or a paralytic ileus. And we're going to learn more about that in a little while as well. This shows you some feeding tubes, right? So nasogastric tube that's connected to a pump, okay, and they're getting feeding that way. And then, the picture down below shows you a percutaneous endoscopy tube. So that's a tube that's going right into the stomach. And a J tube goes into the jejunum. Okay. So we can use these tubes for feedings, gastrointestinal decompression, and what are they used for? And we're going to talk more about what's your role as the nurse. What do you need to be doing to care for these patients that have these types of tubes? Okay. All right. And there's a few review questions at the end, so please go over them, and then we'll do some Q&A. So see you in a little bit. All right, chapter 32, chapter 33 is coming.